Hello, and thank you for joining us for this webinar today. We are ready to begin. Today's webinar is eligible for 1 contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. The speaker and planning committee members have disclosed no relevant financial relationships. To receive contact hours for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees approximately 1 week after the webinar. Following the presentation, we will have time for a question and answer session. You'll see on your GoToWebinar control panel that you can send a message through the questions feature. This is where you can type in any question you'd like to pose to the presenter. Be sure to hit send so the message makes it to us. We'd like to thank our speaker for sharing their expertise with us today. Our speaker today is Michelle Rumsey. Michelle is an experienced international healthcare advisor and policy expert with health professional expertise in human resources for health, health system strengthening, capacity development, stakeholder participation, and regulation in Western Pacific, Southeast Asian region, and Europe. Michelle has particular expertise in providing monitoring and evaluating research and consultating services in the above areas, as well as co-designing capacity development activities targeting health system strengthening through leadership capacity, curriculum development, and faculty development. In her current role, Michelle was assigned to establish a World Health Organization Collaborating Center for Nursing, Midwifery, and Health Development, WHO-CC, the first nursing and midwifery WHO collaborating center in the South Pacific, Australia, and New Zealand. Under Michelle's leadership as director of the WHO Collaborating Center, UTS, the center has carried out 60 projects in 25 countries and coordinated projects to value over $28 million. With a goal to improve population health within the region through collaboration and partnership in human resource for health, leadership capacity building projects. A core aspect of this work is building regional and global partnerships and facilitating and attending numerous global meetings, including WHO Western Pacific Region Human Resources for Health, HRH Strategy, WHO Pacific Human Resources for Health Alliance, WHO Summit for Human Resources for Health, Strategic Planning, Pandemic Preparedness, and Leadership within the Western Pacific region. The WHO-CC also carries out the role of Secretariat for the South Pacific Chief Nursing Midwifery Officers Alliance. This partnership requires a range of skills including consultations, regional strategic planning, networking, negotiation, project management, and the delivery of papers and presentations. Michelle was awarded a UTS Human Rights Award, Social Inclusion 2014 for her work in South Pacific. Wow, we're so great to have you today, Michelle, and we'll turn it over to you.
Thank you. Can you hear me okay, Linda?
Yes, lovely. Thank you.
Excellent. I'm so sorry. My team obviously sent a very long, lengthy bio, and I apologize for all of you listening, but it's an absolute pleasure and an honor to be here today. Very excited speaking to you. And as we all know, it's such a weird dynamic when I can't see your faces and feel your energy. So I hope you can enjoy today's session. And Linda has assured me she might butt in with questions as you have questions as we go along. And please add questions because I'm very happy. I'm from Australia, and as Linda said, it's the University of Technology Sydney that supports our collaborating centre. So we're very grateful to be here in Australia, Sydney. And I must acknowledge the traditional custodians of the land in which I sit, which is the Darubin. And I live on the mighty Hawkesbury River, which is a beautiful river and has a real deep history in this area of the world. So I'm very honoured to live here. And I pay my respects to elders past and present and emerging leaders. So I really just need to acknowledge our custodians of the land before I start. So let me see if we can get this slideshow working. It might be a little bit of a delay for you, so if it is, don't panic. The slide will come afterwards, but we'll just run through. So I'm just going to give a tiny bit. We've already talked about the Collaborating Centre. We're very lucky to have this Collaborating Centre, which is a technical arm of WHO in the South Pacific. And it was actually colleagues from the South Pacific when they set up an alliance that asked us to be that Collaborating Centre, and you'll understand why shortly. This is a picture of that fantastic group, and the group of leaders in the Pacific that we work with change frequently. There are 12 to 14 countries, and we work with a wider group of 22 countries in the Pacific. But as you can see on this picture, we even had Judith Shamian come to one of our meetings in the Pacific when she was ICM president. And the third from the left on the bottom row is Deb Toms, who was our previous chief nurse in Australia. But the reason she's really important was because she was the first nurse on the WHO executive board, and she enabled us to push through the State of the World's Nursing Report, the first report we've ever had, and also the International Year of the Nurse and the International Year of the Midwife. So we have a very big terms of reference with WHO, which is around the South Pacific Chief Nursing Officers Alliance. And we've luckily enough just been nominated for the Global Network Secretariat for the Global Network for collaborating centres around the world. As you've heard from my long, lengthy bio, we work in capacity building, strengthening health workforce, regulation, education, and improving maternal and child health in the region. So today's webinar, we hope to get through some of these things. I hope you'll enjoy it. And it's just really a clearer understanding of the complexity of the health workforce challenges in the Pacific, a brief outline on collectivist and individualistic cultures, and really an understanding of the complex approach to developing this methodology that we're going to talk about today. So I love this Albert Einstein quote. If I had an hour to solve a problem, I would spend 55 minutes thinking about that problem and 5 thinking about the solution. And I think that's a really clear description of the work we'll talk about today. This work really is a body of work over about 10 years. So it takes a long time to develop this thinking, get together, work in genuine partnership. The premise of some of this work that I'm going to talk to today is, although we're nursing and midwifery, really we're a development centre. We work in the region, working in partnership with our colleagues. And historically, there's been a very action bias approach. Go in and solve problems. Nobody's really looked at the individualistic, collectivist cultural paradigms. There's historically been a very colonial approach to research. And we've not really built in as much as we'd like the collaborative co-design approaches, which our collaborating centre has been building on in this last 10 years. We all understand transactional leadership. It's about systems, approaches, but if we're really to get transformative leadership, we've really got to do it in partnership with whoever we're working with. So I'm not really going to say much about this, but you can read the headline, and really it's just examples of good and bad leadership approaches. Some of you may not even know who this gentleman is, but as we're recording this session, he's a very senior leader in our government. We've worked within WHO. WHO has 6 regional offices and regions, and we work in the Western Pacific, which is the dark blue, which is 37 countries. You can see on that map, the red ones are the ones that we'll be talking about today, the South Pacific, but there are also about 22 small islands out of those 37 countries. We also cross over with Southeast Asia, which is the light blue, and those 2 areas condense of about 53% of the world's population. So even though there's 6 regions, these 2 are 53, half the world's population. And yet we sit in the middle of all the natural disasters and historically the pandemics. But as we know, that's quite a different story today. So if we look at the global standard, and for the first time ever, we have the State of the World's Nursing Report. It's so fabulous that we have this report, and I hope you've looked it up and really understand it, because it's a real mandate for us to work forward in the future. It's looking at jobs, leadership, and education. It's a really important report. Globally, nurses are 59% of the health workforce. In our region, we're about 73% of the health workforce, and in the Pacific, we're 74%. We first time have this data. It's fabulous. Globally, nurses are 90% women. In our region, 95% women. What's interesting in our region is we have a very young population of nurses. So 51% are below 35. So we have a very female, very young workforce that are doing the majority of the work. This really is just contextualization. When you look at these figures, the bottom line is a baseline. We need 2.3 per thousand to even meet health needs. And if we're to meet universal health coverage and SDGs, we need 4.5 per thousand health workers of midwives, nurses, and doctors. As you can see across the board, Australia and New Zealand are doing quite well. The countries we work in, I'm actually off to Papua New Guinea on Monday, really struggling in this system. But to contextualize it, when you look at Tokelau, it looks like it has a big health workforce. Tokelau literally only has 13 midwives. And the reason it's good to put this map up is because if you look at this map, it looks like Tokelau is almost doing better than Australia. So contextualizing our thinking to the Pacific is really, really important, because they're very small island states that have quite different needs. So this work came out of a co-designed leadership program across the Pacific. It was designed with our partners because they said that was an absolute desperate need. And we ran the program from 2009 to 2017 when this research started. The reason it stopped then was purely because we've run out some funding and we're about to start again in 2022. It's taken us quite a while to get some funding back up and going and to get the body of research behind the work. The program, really, I don't want to spend too much time on the actual program, but it's really developed in line with the local partners. There's local mentors. It's aligned with the local health plans. Projects are developed. There's a whole variety of aspects of this program that run through UTS and across the region. One of the key components of the program that became very transparent and very important was a 3-day cultural training program within the leadership. It was very interesting for us that when you have many countries that have quite a lot of international donors and quite a lot of international money supporting those countries, what would often happen is our nursing and midwifery leaders didn't have any access to that money. Many of our medical practitioners were able to access money for projects and programs. And we started to understand the difference between paradigms of collectivist cultures and individualistic cultures. And what we do is we work through this framework with our colleagues from the Pacific. As an international development practitioner and a nurse, I'm meant to be culturally appropriate to work in those countries. We never talk to our Pacific colleagues about their own cultural norms and how they are different across the whole region. And so working through this paradigm, they suddenly realized how different we were and how actually in collectivist cultures, it's about keeping the status quo. It's about being polite and coordinating. And the hierarchies are very, very, very steep and high. In Australia, the hierarchies are much more of a flatter system. And we are able to talk up and down our hierarchies. In the Pacific, that's not really appropriate. So for them to understand how to negotiate the different systems, and that actually they can go to the Department of Foreign Affairs Australia and ask for fundings, or what the approaches they need to do within their own ministries to enable them to do that. So lots and lots of information on these paradigms, and if you want to read up more, I'm happy to share documentation, but really just to say this is a really important component of our program, because our colleagues suddenly understood how to make change within the context of their own cultures. So the gap in the literature for this area that we're doing is huge. As I've already talked, action bias, it's been quite transparent that a lot of work has gone in and researched on our Pacific colleagues and not really involved them. And so the top-down approach has shown clearly over and over again, it does not work in the Pacific. And there's a new growing body of evidence that shows that. So really important that finally we've got some clear evidence to say top-down approaches just don't work. We know there's a body of evidence and information around the Pacific where they struggle. They've got an increase in NCDs. It's very expensive to travel across the Pacific, limited human resources, limited investment in health, many, many issues and challenges for the Pacific. I love this map. This map is a newly designed map by a Japanese colleague, and it really is meant to be the most accurate portrayal of how the globe is if we flatten out a globe. And so what you can see is the Pacific really does sit within a third of the global space. If you understand when we go from Chile through to the US and Canada, and then come down to Russia and China and all the way down to the Pacific, that whole bowl is what they call Apec, the Asian Pacific Economic Communities. And so Apec is a discussion body where it talks about all of these countries. But when you look at it this way, it's not really a surprise that the Pacific Islands, those 22 tiny islands that I showed you before, are really almost a political discussion between all of these countries surrounding them, and it sort of gives a better context for why they struggle. So I've just skipped a slide, but it's fine. It's really a slide that shows about the lack of the need for strong leadership in the Pacific, and there's very little leadership programs that have been developed, contextualized for the Pacific. But obviously in these isolated islands with very few health workforce and often one chief nurse with nobody else in the ministry, leadership is really important. And one of the reasons that we set up that leadership program at the beginning. If you look at the global literature, what we discovered is there's very, very little Pacific evidence, very little evidence or publications developed by our colleagues in the Pacific. There have been many. We know that nursing leadership reviews and literature on leadership in nursing is huge, but even many of the systematic reviews did not cover these small islands. It covered many more countries like Canada, Europe, US, Australasia, but not really the Pacific. So a huge gap in the literature there. So this led us on to needing to develop a really appropriate methodology that would work within the Pacific. Linda, I'm assuming that we've got no questions at this stage?
No questions in the chat. I do want to say, as a nurse myself, I am shocked that of the lack of literature, especially in the systematic reviews that showcase and highlight this particular region. So I'm watching the questions, of course, but I'm also very, very interested in the topic.
Great, that's fantastic. And please butt in, because it's like very lonely sitting here in Australia. So I'm very happy for you to chat to me. Okay. So developing a framework, we needed to develop a framework that really was culturally appropriate. We saw this huge gap in the literature. We needed to develop something that enabled the leadership to be translated to policy, that the leadership would meet universal health needs, but also, more importantly, that it valued and acknowledged the Indigenous people's perspective on worldviews within the research process. There are a lot of frameworks, guidelines around doing cultural, ethical approaches to research, but there were very few that gave a practical stepping stone on how to. So Linda Dwelly Smith's foundational work is really fabulous work if you haven't read any of her work. And her work is really around the fact that conventional research methodologies are problematic because they really are linked to an imperial colonial paradigm. And in a concept where our partners haven't been involved, often a research process is seen as some a Western approach, going in, taking information and coming away. So obviously there's lots of her literature, and other colleagues in the Pacific have talked about the need to really understand the need and value the contemporary life in modern day society. A lot of our historical thinking is very, very old. So how do we genuinely ensure we involve the context in which the research is being carried out? So what we've worked on in a co-design approach with our SPC and MOA, our leaders of the Pacific, is marrying some different approaches. So we looked at participatory action research, and we looked at two Pacific frameworks, Telenoa and Cacao, to really build on that. We looked at ethnography and a variety of other approaches, and although ethnography is used a lot in social science, it was seen still as a top-down approach, and so participatory action research was the method that was chosen. And so participatory action research has been around for a long time. It's been around since the 1960s and 70s. It's been developed and adjusted in many approaches. A lot of community approaches use participatory action research. A lot of health practitioners use it in their research. It's very highly regarded. And it really is important because it looks at shared power. It looks at reciprocity. It looks at about a reflexive approach. But it also says that the locals are seen as the expert and that they can guide and evaluate the work. So it's really the beginning discussion of a partnership model. But still, for the Pacific, with the difference between individualistic and collective cultures, we felt it didn't go far enough. So we incorporated and married into this approach Cacao too. Cacao is a beautiful approach. It's about the art of collaboration, and it really is the bedrock of collectivist cultures, where people sit together and discuss things and actually work out problems together. That actually the hierarchies of the culture are acknowledged in a beautiful way. So as an international visitor, I'm often met at the airport and honoured in a certain way, which for a development practitioner feels very uncomfortable. I don't want to be put up on a higher pedestal. And so navigating and negotiating where I sit to ensure that I still have mutual trust and work alongside and behind my colleagues in the Pacific is a dynamic that it requires some work. So Cacao, understanding that art of collaboration and how to work together in a respectful way is really important. Telenoa is understood a little bit more in the Pacific. It's another Tongan approach. And Telenoa is written quite widely. There's a lot of referencing and a lot of documentation on Telenoa. Where Telenoa is beautiful and I like it, it really does push out some of those paradigms around research for the Pacific. It really does stretch some of our thinking. Words like not being over smart, about sharing, about gifting information. When we go into a country, we often take memory sticks when we're meeting with many people with our SPC and MOA co-design partners. We make sure that there's a communication and a dynamic that is happening. We're very respectful and humble. We make sure we dress appropriately, but we always take the lead from our Pacific colleagues who are co-designing. We wait for them, we check out what's happening. But also, even in my university, I don't have any pictures of my family around my desk. I go to work, I live in an environment which is a university environment. When I go to the Pacific, you always ask about family, you talk about children, you have a sort of respect for their context of how things are important. I've been in ministries of health now when the CEO has walked through the whole ministry and said, my mother's really ill, I'm sorry, I've just got to go and check on her. It's not a thing we're used to in Australia or the Western world, where the senior person will say, it's okay, my family member is really ill, I'm just going to check on them. So actually understanding this context is really important. When you look at this beautiful picture, this is in a lagoon of Kiribati, and it's full of E. coli. You would never swim in that water. You wouldn't go near that water. And the only way I say that is because really contextualizing where we are and how we are is really important. You'll look at this picture and think it looks absolutely beautiful. So really understanding the context is very, very important. So we've married this this framework together and called it Pacifica, and really we've started to unpick some of these dynamics now. So what is co-design? It's about partnerships. It's about ensuring that the lived experience of the individuals who are partnering with us are valued. It's about acknowledging the power imbalance. And I think that's really important, because acknowledging the power imbalance between Australian researchers and our local partners and our local co-design researchers on the ground is really important. It's acknowledging that and discussing it and talking it through. It's about delivering of results that are shared so that there is genuine sustainability. Then you've got the participatory action research paradigms around the outside. And then what we've done is we've combined all of those to look at some areas that really do overlap between all the different research methodologies and built a framework around those. So looking at safety, respect, collaboration, beneficy and reciprocity, relationships and justice.
Hey, Michelle.
Yeah.
When I look at this and I see the components of safety and respect and relationships, that actually reminds me of Maslow's hierarchy of needs.
Yeah,
Do you see the
absolutely.
correlation?
Yeah, absolutely. I mean, and it's really just going back to basics, but then it's articulating it into some words that really make sense. And we've tried to do that in a bigger sense, because like I said, with the original guidelines, everybody knows we've got to be culturally appropriate when we carry out research, but the how do we do that?
What does that look like? Yeah.
Yeah.
Awesome.
So again, just a tiny bit more information around co-design that's around working in partnership, planning, delivering and evaluating and solving a problem. And sometimes this is a little complex for researchers because they're so used to following very clear, strict guidelines around ethics and consent and all of those approaches, which we obviously had to fulfill within a university. But how we can adapt that information to make sure it was appropriate for our Pacific colleagues. The concept of consent is quite an unusual one for the Pacific. They'll just say yes, a Western colleague has come in, they'll just sign a form. So really understanding what consent means for them in their context is really important. When we look at safety and collecting data in partnership, it's making sure that everyone feels safe to speak up. and especially if they have any concerns. And that's a huge thing, again, in a cultural dynamic. Respecting the partnerships, genuinely listening, acknowledging non-verbal approaches is really important. I've been in many Pacific meetings where I joke that I speak Pacific eyebrow. And if any of you know, colleagues, when you're in a very hierarchical meeting and a very senior person is speaking and nobody's allowed to say anything, you can literally see the eyebrows go around the room. They've all, oh, they've just agreed to that point. Oh, or maybe they haven't agreed to that point. You can actually work out by the non-verbals what people are thinking when people culturally aren't allowed to speak up. So understanding the non-verbals, incredibly important. Collaboration goes without saying, it's what we do, it's our core business, but really collaborating in genuine partnership, listening, being there for the long haul, the longevity, building those relationships are very, very important. So reciprocity, beneficy, it's around enabling generosity, helpful reciprocity. So if the relationships are developed over time, there is a genuine reciprocity to help you support things. Colleagues would often spend 2 days getting to us from outer islands. And that meant that there was a genuine mutual learning, a genuine mutual respect. And we'd always honor that by not having a very short interview. The interview could go on for half a day. We'd never have a half-hour interview. If they wanted to talk to us about professional issues and other things outside of the research process, we were very happy to do that. It was about respecting them and understanding the energy and time that they've spent coming to see us. Justice, crucial, making sure that individuals' voice is heard, making sure that the environment is safe. If you're on a very small island, we always make sure all our colleagues and researchers, when we go to outer islands or even any Pacific island, we never speak about the process going in on the plane or coming out on the plane. There's a few people on these planes. Everybody knows everybody. You keep confidentiality very close. And you also look at the environment. Are they close to managers? Are they able to speak out? Where's the environment that they're sitting, to ensure that it's genuine? And also that next stage, if we don't have any evidence, how do we build this knowledge base so that we can actually genuinely produce joint publications so that they start to have their own evidence for the Pacific? I've talked a lot about relationships, but again, that just goes on to the honesty of a response. If you have a genuine relationship and the individuals genuinely feel safe, we are more likely to get a honest response to the research, rather than maybe a collectivist approach, which is about not wanting to ruffle feathers, wanting to try and please everybody, trying to meet the needs of the international colleague who's come into country and say what we think they want them to hear. But if you have this safety, if you have this relationship based, you're much more likely to get a genuine, honest response to the questions being asked. So the research aims, I'm really just starting now to go a tiny bit through the research and outline how complex it was, and really that it's really about identifying barriers and enablers to maximize nursing leadership contribution to health, the linkage to universal health coverage and positive pathways, that transition of policy to practice and the transition from leadership to policy. Quite a big study and quite a lot of information. So the research process was carried out in a very normal process. It was qualitative study using the Pacifica as a methodology to ensure the cultural sensitivity, as I've already said. I've already talked about not being time limited and enabling the voice of the Pacific to come out naturally. All of these things are more of the Western approach, but following those processes. The countries involved, there were 12 countries involved in the leadership program. So we had to set up a criteria with our partners in the Pacific to work out how to pick some of the countries. We couldn't go to all of them. And so we worked out representation from Micronesian, Melanesian and Polynesian, which are the three groups in the Pacific. And we also looked at very small islands and slightly larger islands. We also looked at, they were all low middle income countries. And so the countries not involved were Tokelau, Niue, Cook Islands and Papua New Guinea, but we involved all the other countries, as you can see at the bottom, Nauru, Kiribati, Fiji, Vanuatu, Solomons, can't read the lines, but anyway, a lot of those, you can see them on the map probably easier, countries involved in the study. So one of the things that we had to do was to map stakeholders. It's quite a complex process, especially when you're working in development and across regions. So we had to, with our partners in the South Pacific, map who we involved. We also had to do a rapid review to look at some of the influences on leadership to work out who those stakeholders were that we wanted to involve. And so we set up four areas of key influence, which were the external influences on the Pacific and on the islands, the finances, disasters, regional and global strategies, giving them so much pressure. Then looked at the institutional architecture. So within a health sector, who were the power players, who were the actors, where were the movements in the hierarchies, were people able to carry out the knowledge and understanding? So how our colleagues learned around leadership, the leadership fellows, how they got their knowledge either from the program or other things, and then the personal agency, what changed for them, what they needed to enable them in their context to be a good leader. That led us through this mapping to work out who we were going to interview, and we set it up into 4 groups. The 3 and 4 had quite extensive interview process, and group 1 and 2 had a smaller questionnaire. And you'll see that from the 207 individuals mapped, we ended up being able to interview 136, so a 65% coverage, so quite a good data coverage. When we look at the fellows, the leadership fellows who've been involved in the original leadership program, so they were one of our sample groups. There were 66 within the countries we went to, and out of those 66 we were able to interview 50, so quite a good data saturation of 75%. So it was quite a big study. Challenges. I mean, huge challenges in the Pacific. The reason with all the cultural norms we had and the non-verbals, we had to be in country. You can't do these interviews over Zoom or by phone. We did do 2 or 3 phone calls to Tokelau because it literally takes 2 weeks to get in and out by a boat. We couldn't travel there. But other than that, we went to I think we ended up doing 30 flights over the 3-month period to the 10 countries, even though 8 countries were only involved. We had to keep going in and out. To get to some points in Kiribati, we had to keep flying in and out of Fiji to get to other points. So even within their countries, travel between countries is nearly impossible. So with this expense and with the time it takes to get to these countries, it's no wonder that research isn't carried out in genuine partnership with our colleagues, and it's no wonder there's a gap in the knowledge. The other aspects are really, really important is that we needed at all stages to have ministerial approval and ethics approval in different countries. Complexity of interviewing senior colleagues with our partners, just making sure that the cultural norms were met. And while having a partner in country, there were many moments that were tricky, and having that mutual respect and acknowledging those hierarchies. There was one moment when I went in to meet a Minister of Health, And the chief nurse of that country came in with me. And because I'm a director of a WHO collaborating centre, even though I'm a woman, you use that kudos. You enable your chief nurse of the country to come along when sometimes they have tricky meetings. And we outline some of the works they've been doing. We have a pre-meeting. We work out if there are any things that they need to speak to the minister while we're also interviewing the minister, ensuring that all the cultural appropriate processes are carried out all along the way. But in this one meeting, we got to the big table, we did all the meet and greets, and I turned around to discover that the chief nurse was at the other end of the room, sitting by the door. And it was really confronting for me because I didn't know how to manage that, because I sort of said, would you like to come up? And she nodded no. And so I culturally had to respect that she wasn't going to come to the main table. I never had a meeting with the minister again without absolutely clarifying with the chief nurse of that country at what stage culturally, because I should be walking behind and alongside my colleagues. I should never be up front. But culturally in that country, at that moment, that chief nurse felt more comfortable not being at the main table. And I had to respect that, but really, really hard as a Western researcher. All of these things, limitation, time, huge amounts of time taken for even just collecting data. All of those concepts of lack of knowledge and evidence, we had to really search for PhDs within the region. A few of our colleagues now are getting better at doing PhDs, so we were able to delve down because very little publications. And so there are some significant limitations, and as I said at the beginning with the co-design, ensuring that power imbalance was acknowledged and talked about, and my discussions with that chief nurse afterwards of how I should have dealt with that differently, or did I deal with it okay, when those power imbalances are absolutely there. So, Linda, I've got just a couple of slides on results. Do you want me to keep going just to give a sort of finale?
Yes, absolutely. Please keep going.
Okay, good. I will do. So, just a few pictures here of our colleagues. We're very lucky through the leadership program and through some of the things we now have 2 health ministers in the Pacific through our leadership program, and who've obviously done other work as well from the original work. And 8 to 9 of them are also succession planning is working. So the leaders of the leadership program are enabling themselves to be in a position to get to those leadership positions. I think what's more important and quite amazing is that if you've got these very small island states with all these cultural hierarchies, to get 9 self-funded to the World Health Assembly, which makes all the decisions on the global health platform, is really important. I haven't got a picture here, and I should do, because I normally put a picture up, and I might do in the next session, of just looking at the World Health Assembly, of how that dynamic is historically very male, lots of black suits, very few women there, although it's getting better. But the decision making for the world is often with many of our medical practitioners. So ensuring that our chief nurses have the power and knowledge to attend those massive global forums, where when individuals come back to our countries, they actually set the scene for the next few years and financing. It's really important. That first picture that Dr. Tedros at some of our regional meetings actually appointed Lizira from our region to be the chief nurse in WHO headquarters was such an honor. And that bottom picture is our colleagues at the World Health Assembly, and just that colour and vibrance of our Pacific colleagues at WHA always makes me laugh. It makes me so proud when we see just a different dynamic in that room of decision-making processes. The bottom far picture with lots of is really important as well, because making sure that we're at the regional infrastructure meetings, the Pacific heads of health and the Pacific ministers meetings is really important, and making sure that our colleagues are confident to articulate things at those meetings are really important.
Michelle, we do have a question. How can a
Yep.
nurse from America become involved in research in these areas?
I guess there are a lot of American Pacific Islands. There's about 10 of them. There's a Pacific Leadership Council that we link with. And Robert Wood Johnson, and I hope I've got that correct, does a lot of research in the region. And if an American nurse wants to get involved, there are lots of platforms to link up with. Because we have these 10 American Pacific Islands, so there's American Samoa, and I'm so sorry, maybe in the next session I'll put the American Pacific Islands up too, to give the context for you too, because it's something I just didn't think of, although I often share that information. Because when I said 22 Pacific Islands, we're working with the 12 to 14, but we link over with the other 10, which are often American protectorates: Guam, Federated States of Micronesia, there's quite a few that work very closely with the US. So, and they desperately need support and help. And there are lots of, USA does a lot of work in the Pacific. So there are definite avenues, and maybe I'll have a look at some of those examples for our next presentation.
Awesome. Thank you so much for answering that. And as Michelle mentioned, she has some more content, but this is a two-part series. So we, of course, would love for you to come back and listen to part 2 and have some more dialogue with questions.
Absolutely, because what I'm really like, especially if you're enjoying this, is think about it between now and the next session and have some really good questions to bring up, because the dialogue's much more important for me, because I really need to know your thoughts and any thoughts you've got about our methodology, how you can get involved, all of those things. And these questions will help me think about planning the next session too, which is really important. So I haven't got many more slides. This really is just, we're very, very lucky that the State of the World's Nursing Report actually highlighted our leadership program in their report. So that's a great honor for us, and some information in that State of the World's Nursing Report. This is a universal health coverage framework that we use in the Western Pacific. And I think I really love this model. And it's a model that we've used to articulate whether some of the programs and the projects are meeting out of this research universal health coverage. And it's got sort of 5 clear areas around quality, efficiency, equity, accountability, and sustainability. So it's a beautiful framework to match back against whether some of the programs and projects and leadership work have come forward. And so even though I'm not even beginning to talk about the results of the leadership at this stage, these are just really highlighting some of the stories from the leadership work that have shown the gravitas and output from the leadership programs. And if you come next time, I'll talk more about the results of the study. But what clearly showed was that through the leadership program and that building of abilities, they were able to make significant change. And then we mapped that a little bit back against UHC and universal health coverage, because it's trying to articulate this in a way that makes sense for both the strategists, the government of the day, the Minister for Health, so that our chief nurses and our nursing leaders actually can say, look, we are making a change and we are meeting your targets around universal health coverage. And there were lots and lots of beautiful examples around individuals going back, and a lot of the research, the leadership program was around data literacy, understanding if nurses often collect data all the time, but how they could articulate that in a way that made sense and to empower them to use the data they were collecting. And so one individual had realized that mothers weren't coming to antenatal, and they'd been monitoring that for years, but they'd never done anything about it. So when they went back from our program, they actually started talking to the stakeholders and chatting it through to realize that actually in the collectivist cultures, their partners weren't able to attend these meetings. And so they weren't able to go. So it was a very simple change that they were able to change the meetings to enable their partners to come, and they increased immediately from a 25% attendance to a 60% attendance. Lots and lots of just information around funding. One gentleman realised that the maternal mortality rate in his whole province was so low. In discussing things, he looked at the health workforce, realised he had very, very few midwives, went back to the National Department of Health, negotiated to have more midwives. And these are big provincial leaders. So the individuals on our programme are not everyday nurses. It's about succession planning for the chief nurse role. So it's high level policy development. And he realized that in negotiation, and because we've been monitoring these programs for many years, it took him quite a few years to get the ministry to increase the number of midwives. And he now has one midwife per health centre, and he's seen a significant reduce in the mortality of mothers. Many different areas, looking at drugs and quality and service provision, and looking at how that could be improved. Another fellow was a hospital senior leader and realised that they really weren't analysing the effective staff location of the needs in the hospital. So she set up a system to carry out some of those things. And other stories around HIV in really remote communities, and through discussions setting up some really good community balances. And again, it's what's interesting in collectivist cultures, even though everybody works together, there's not as much networking as you think, or sharing of resources. So it's often enabling our colleagues to have the confidence with their knowledge base to go out and work with. And I think one of the things that we found within the programs was actually their ability to go out and really do that mapping of stakeholders for themselves to work out how to improve things locally within the communities. And one of the outer islands in Kiribati worked out that they just weren't getting the young people to the community centres, so they started setting up some drumming competitions, and then got lots of people in to talk about HIV and health needs. So many different programs, but these are just examples from the sort of field work of things that had improved over the years, and not from the main research. So next time, really, I'm hoping to share with you some of the actual results from the major study, looking at the enablers and inhibitors of leadership within the Pacific, what came out of the research in a positive way. We have many joint publications planned, and several out there. We have, and how we've used this Pacific methodology in other programs across the region, and enabled sustainability with our colleagues to take on this methodology in a different approach. We have quite a few publications out at the moment, and a lot of what I'd call reports jointly produced by our colleagues. But this one has just been published in the Lancet in the Western Pacific, so it's a really nice publication, and it was produced by with us and the previous chief nurse of Fiji, one of our professor colleagues, the chief nurse of Solomon Islands, and the chief nurse of Nauru. So definitely a joint publication, and all of our publications are joint from any of our programs in the region, but this is a nice one that you might find useful to get a bit more background on some of the work we're doing to sort of synthesize some of your questions for the next session. My contact details are underneath, and thank you very much.
Wow, this has really been great. I personally did not know all of the work that you and your team has put into to really showcase the region, and even your presentation today really does highlight, and I'm sure it doesn't even touch on all of the details. We do have a previous regional coordinator of Sigma on on the call today, and she said that we do have members in Guam, so it might be helpful for nurses from the USA to help in that regard. And then we also have a question just in general about research projects. So this might be, it's a little stemmed off of your content, but does a nurse need any special qualifications to be involved in research projects?
Yes and no. I think what I try and talk about is I'm obviously in an academic institute. I sit within a university, and we're trying to build the evidence base for our Pacific colleagues. And I think that runs across nursing per se anywhere. And one of the things that we've tried to do is, instead of talk about research, if you haven't got research experience, is start in a level like you're doing today, coming on today's session and understanding data literacy. Look around yourself, work out what smaller projects you can be involved with. Within the development world, we have many levels of collecting data. So we do what we call MERL, which is monitoring, evaluation, research and learning. And so you don't need high level research skills to be involved in sort of some of that data collection and support, but it's really about long-term building your skill sets if you really do want to become a nurse researcher, because I think there are several levels. And even, you know, building your skills locally and reading lots will enable you to think which way you want to go. I'm not sure if I've answered that very well, Linda, but it's really, I think in our world, there are so many opportunities for people to get involved. It's almost, we're always happy to have support and people who are genuinely interested.
Yeah, I think that really does answer it. You know, I think a lot of times nurses, if they're at the bedside, they might shy away from things with research in the title because it's scary. But once you start and just like joining this webinar, get your feet wet and see that there are various vehicles in which you can be involved in research to drive the profession and to really showcase all that we have to offer.
And I think in the Pacific, the confidence and courage that has come out, which I'll show in the next presentation from our colleagues going through this work, is really important. And really, at the end of the day, if you see a need in your clinical area, even if you do it as a personal, you know, evaluation, then start reading around it. This doesn't seem right. We seem to have a problem here that's reoccurring. Anybody can, it's about being inquisitive and thinking and looking outside instead of just going to work every day. Like, this really seems a problem. Have we really addressed this in the right way? And start monitoring it yourself quietly, and then find articles that will help you build up. It's very easy to start making change in a small way in your own environment. And I think that's really, really important.
Yeah, I love that. Thank you for sharing that. Michelle, that is basically all the time we have today and all of the questions. So I want to thank you so much for sharing all of this great information. Sigma is grateful that you took the time to share with our audience, and we definitely look forward to part 2 and for hearing more from you in the future.
Sorry.
We hope you enjoyed this webinar. As a reminder, 1 week from today, you will receive an email with the link to the evaluation to complete the evaluation and obtain your Nursing Continuing Professional Development Certificate. Please be sure to check out Sigma's upcoming webinars and resources to support you and your colleagues at sigmanursing.org. Also, previously recorded webinars are freely available to you on the Sigma repository. Thank you so much for joining us and have a wonderful day.